At ACR this year, we're presenting circulating tumor DNA status to direct adjuvant immunotherapy for mismatch repair-deficient tumors. This is an investigator-initiated study that we conducted at Memorial Sloan Kettering across multiple disease management teams, and multidisciplinary involvement was very important because it's a study to elucidate the role of ctDNA to help guide adjuvant therapy. We know that ctDNA is a real-time biomarker for minimal residual disease and cleared within hours after complete resection and definitive therapy, and that persistent or recurrent post-op ctDNA strongly predicts a risk of cancer recurrence. In mismatch repair deficiency tumors, the role of adjuvant therapy has not been, with immunotherapy, has not been well characterized because those tumors are cured with surgery alone, and adjuvant chemotherapy offers limited benefit. We know that immunotherapy is highly effective in MMRD tumors in metastatic and neoadjuvant setting, so there's been no studies that evaluated ctDNA-guided adjuvant therapy in MMRD tumors. Our hypothesis was that ctDNA detection post-surgery signals residual disease in MMRD tumors and may identify patients who require adjuvant immunotherapy. So our study looked at patients irrespective of tumor origin who had mismatch repair deficient tumor and based on tumor normal DNA sequencing. After surgery and completion of standard chemotherapy, after the patient was told by their doctor that they're finished and they're cured, we had a tumor-informed ctDNA assay performed using MSK Access. And if the tumor was ctDNA positive, if the patient was ctDNA positive, they were eligible for the study. We then obtained CT scans to make sure the tumor has not recurred. And if the patient was without evidence of disease, then observational adjuvant pembrolizumab was given for ctDNA positive for no M1 disease on imaging. If they were ctDNA positive, but they had already radiographic recurrence, they weren't eligible to receive adjuvant pembrolizumab. And if they were ctDNA negative, they were followed for recurrence and serial ctDNA in the observational cohort. So every patient across these cohorts had a surveillance every 3 months with imaging and clinical follow-up and ctDNA. We actually first designed this study as a placebo-controlled study, but after having the study open for over a year, only one patient consented, and this was felt to be not feasible, so we closed the placebo arm, and enrollment was completed for December 2023 in a single-arm study. For ctDNA detection, we used MSK Access, which is a custom hybrid capture ctDNA assay that targets 129 gene and incorporates tumor-informed analysis and de novo mutation calling. So everybody had MSK Access, but also MSK Impact, which is the tumor analysis, and the mutations across the tumor and the ctDNA were compared. And if they had at least one positive match, they were defined as ctDNA positive. And this was the match between blood and tumor and ruling out germline alterations. So we screened 303 patients, ctDNA tested 184, and 174 were eligible ctDNA tested. And then ctDNA positive patients that went on to receive adjuvant pembrolizumab, there were 13. ctDNA positive patients that had M1 disease before adjuvant PD-1 was 6. And then ctDNA negative, no adjuvant pembrolizumab, 152 patients. These were relatively high-risk population with node positivity seen in 40% at pathologic surgery. And as I mentioned, 84% of patients had ctDNA done by MSK Access. We also had 16% who had outside CLIA-approved assays. These were non-germline patients. Mostly 72% did not have Lynch, and the median tumor mutation burden was 50. Looking across the different diseases, as I mentioned, this was irrespective of tumor origin study. And we screened the predominant population of patients we screened was colorectal, endometrial, and gastrointestinal, upper GI tumors, gastroesophageal cancers, and 9% of colorectal tumors that were screened were ctDNA positive, while 35% of gastroesophageal cancers were ctDNA positive, again highlighting the difference in the tumor presentation and stage. Overall, 11% of MSI-high patients were ctDNA positive after completion of standard surgery and chemo treatment, and all patients had tumor sequencing by MSK impact with matched ctDNA tumor match of 6 mutations with a range of 1 to 12. So looking at recurrence-free survival, as expected, ctDNA negative patients, most of them are cured with no additional therapy, and 94% recurrence-free survival at 2 years. ctDNA positive patients that recurred before anti-PD-1 therapy, all of them recurred within a year. And there was a cohort of ctDNA positive adjuvant anti-PD-1 therapy, which is our primary therapeutic cohort, where recurrence-free survival at 2 years was 64%. So 94% recurrence-free survival for ctDNA negative patients, 0% for ctDNA positive patients at 2 years that did not receive anti-PD-1 adjuvant therapy, and 64% recurrence-free survival at 2 years for ctDNA positive therapy treated patients with adjuvant PD-1 therapy. Our primary endpoint was rate of ctDNA clearance at 6 months, and looking at 6 months ctDNA clearance, 85% of patients cleared ctDNA at 6 months, which has exceeded our threshold for success for the study. We defined it as 40% positive patients cleared at ctDNA at 6 months. The median time to clearance was 3.9 months. Despite clearing ctDNA at 6 months and 100% cleared at 9 months, radiographic recurrence was still seen in 5 out of 13 patients, with 38% of patients recurring overall. So ctDNA patients treated with pembrolizumab had numerically similar time to recurrence as ctDNA negative patients who did not receive adjuvant therapy, suggesting that immunotherapy may suppress or delay outgrowth of residual clones. The time to ctDNA positive to recurrence, it was approximately 20 months. In conclusion, our study showed that 94% of MSI-high ctDNA negative patients remained disease-free at 2 years. 11% of MSI-high patients had detectable ctDNA after standard therapy, and 85% of ctDNA positive patients cleared ctDNA within 6 months of adjuvant therapy. What's important to note is that 38% of patients recurred despite ctDNA clearance at 6 months, and so additional interventions are urgently needed for this high-risk group. And bespoke ctDNA assays may offer modest lead time gains in MSI tumors, but really what we need to focus is on more effective treatment strategies. This study provides the first prospective clinical evidence that immunotherapy can clear residual disease before clinical recurrence, highlighting ctDNA's dynamic tool to guide treatment in early-stage cancers.